Hello, good afternoon, everyone. Good morning for those of you connecting from Americas. Good evening is somebody of you is connecting from the Eastern countries. Welcome to this EV webinar in which we are gonna discuss and present three very interesting presentations in which we're gonna cover how this pandemic has changed our practice, how we are going to have to prepare our patients in front of their processes, which I think that is really, I think it's something that we're going to need in the next, we don't know for how long. At this point, we don't know if all the measurements that we are taking are going to stay with us for just a few weeks or longer. But nowadays, everybody wants to know what should be done in order to work as safe as possible. So with this purpose, we have today three very renowned speakers, three experts on their fields. It's gonna be my pleasure to introduce our three speakers today. We will have Dr. Pellicer, who is going to speak us on how the preparation in terms of immunological exams should be done in front of an ART treatment. And afterwards, Dr. Alecsandru will talk to us on the preparation for patients in front of pregnancy. And finally, Dr. Alberto Vázquez, who is the chief surgeon of the IVI group and working in IVI Barcelona and IVI Madrid, will present us on the preparation for patients under surgery, undergoing surgery. We are going to have three presentations of about 20-25 minutes. During this time, you will be able to upload your questions. On the bottom of the screen, you have the Q&A option. So you will be able to post there your questions. We will be receiving them. And after the three talks, we will have time for discussion. We will be recording the questions that you're doing, and we'll be making them to the three speakers. So I encourage you to take the opportunity to make any questions that you may have to our experts, because it's not usual that we have the three of them together, so we need to take approach of it. So with no more words, I'm gonna give the word to Dr. Pellicer, as you know, president and co-founder of IVI, and today working in Rome, and he is going to talk us about preparation before ART treatment. Please, Dr. Pellicer.
First of all, thank you very much for your introduction, Ernesto. And also, I really appreciate that people from all over the world has joined us to make some points that, as Ernesto said, what we are saying today may not stand next week or maybe in 1 month, because we are continuously learning about the disease and how we have to manage it. So the points I'm going to make today are related to why do we care about the potential effects on ART treatments. And I'm going to focus first to show you what we know about the risk of having contamination in the gametes and embryos, the effects on pregnancy and the teratogenic effects, and finally the transmission to all the people working around us, and the series of measures that we take in our patients and also in our staff. So it's important to remember, as you see on the right-hand side of the slide, that apparently only 5% of the population is immunoprotected. In other words, 95% of us are always at risk of being somehow contaminated. So I cannot So to understand what's going on with the virus and the reproductive cells, it's important to remember how the virus enters into the cells. And as you can see here in this drawing, the virus needs a specific receptor called ACE2, and also a serine protease, which functionally acts together with this receptor. And this is the entrance, the mechanism of entrance of the virus into the cells. So for us, it's important to understand whether these two particular receptors are present in the gametes and also the endometrium. But I'm not going to discuss today about the endometrium, and I'm going to fix my attention to the moment in which we want to work with sperm, with eggs, and with embryos. Now, regarding sperm, to my understanding and to my knowledge, this is the most important paper published so far. It has been published in Fertility and Sterility. You can find it online already. And the paper is important because it shows you, as you can see here, the presence of both receptors for ACE2 and the serine protease in the different cells of the testes. And it comes out that regarding sperm, which is number 8, this is the population found in the testes. And if you see here in this panel, none of the two receptors are found in sperm. So in theory, the virus cannot enter into the sperm and be the source or the door of entrance into an oocyte to get into to be replicated into an embryo. This is not possible because the receptors are not present in the sperm. The second point is whether the virus can be present in the seminal fluid and be a source of sexual transmission as other viruses are. And to answer this question, we have 3 papers published so far in the literature. This one here analyzed 34 patients who were all of them positive for PCR, so they were ill, infected, and they were subsequently negative. And in all the 34 patients, in none of them, the analysis of the sperm of the semen sample was positive. It was negative in all of them, 100%. Some of them had some scrotal discomfort, but that might be associated with infection. But the answer to that paper is, in this paper, is that the virus cannot enter in the sperm, and the semen is not contaminated. Then you have another manuscript published a little bit later in a journal of the JAMA family. And in this manuscript, they initially have selected 50 patients, but in the end, they were able to analyze samples from 6 patients. And the paper found some sperm with a positive RT-PCR, but in reality, the method of RT-PCR was not clearly defined in the manuscript. There was no confirmation test for real infection, and there are no also explanation of hygienic measures that maybe explained to us while the semen sample was contaminated and not the virus was present in sperm. And so I have serious doubts about this paper because of the methodology, because the number of individuals involved. And we recently accepted a manuscript. I have difficulties in going forwards. Okay. We recently accepted a paper in fertility and sterility, so I got permission from the authors to show you this, the outcomes of this paper. This is coming from Germany and from Düsseldorf, and the paper was accepted just a couple of days ago. And basically, they included also 34 individuals and analyzed the sperm or the semen from 20 individuals who were positive for COVID again, and they were unable to find a single case that was positive in sperm. So again, the conclusion is that there is no viral transmission during sexual contact. So this is with regard to the sperm. So in the next slide, I show you what is relative to the oocyte. This paper has been also accepted in fertility and sterility, that, as you see, is becoming the reference journal for us for reproductive medicine in this particular topic. And again, the picture is very similar to what you see in what you have seen for sperm. So this part of the slide identifies to you the different cellular components of the ovary, and here is the oocyte. So when it comes to the presence of the two receptors that are pertinent to the potential entrance of the virus into these particular cells, here we see a difference. We see that there's some positive signal of both, especially ACE2 in the oocytes. However, the granulosa cells that surround the oocyte are totally negative. And I just show you this drawing to make the point that the oocyte is surrounded by granulosa cells that cannot, where the virus cannot enter because the receptors are not present. So the risk of viral transmission through the oocytes to potential embryos is very low. It's very, very low. In the next slide, I show you what has been published so far for embryos, for human embryos. There is a paper published that here you have the reference, and the authors detected in human embryos the ACE2 receptor, but the presence of the necessary serine protease is not mentioned. And in the next slide, I show you what is known about potential pregnancy. You know probably more than me. Maybe the previous data were unknown to many of you, but these data are quite known. And basically, we know that the maternal infection is associated with a clinical picture, which is not as fatal as were other coronavirus infections. We know that the signs and symptoms in pregnant women are similar to non-pregnant women. We know that pregnant women are not more susceptible to coronavirus infection than others, and therefore they are not considered a high-risk population. Still, we are learning some potential complications, such as premature labor and some thrombotic disorders that have been related in some case reports, but I guess, and I think that Dr. Alecsandru will develop more this concept. And basically, it's quite reassuring that there is no vertical transmission to the fetus, to the baby. And in fact, there is no contraindication for natural pregnancy. So if there is no contraindication for natural pregnancy, it shouldn't be contraindication for ART. And this is the point that we make. We reopened our clinics 3 weeks ago, and we are proceeding with our treatments. Now, the question is, how do we want to manage our patients in these circumstances? But remember that we are not concerned about the sperm. We are a little bit concerned about the oocyte because it has the receptors, but again, it's protected by the granulosa cells that do not have these receptors. And the same is true for the embryo. So if sperm and oocyte do not carry the virus, even if one of the two receptors necessary for the embryo, for the virus to enter into the embryo, are present in human embryos, we shouldn't care. But again, we want to play always in the safe side, and we want to learn how to manage the whole thing. So, and this is probably the most important slide of my presentation. In this slide has many messages. The first one is that when the virus enters in contact with a human being, it takes approximately 1 week to start to be detected, the virus in the swabs, okay, in the nasopharyngeal swabs. And in reality, it takes about 2 weeks altogether to get sufficient presence of the virus to be positive, the PCR. And basically, when the symptoms start, you can get the PCR, you can get a positive PCR. But remember, this week, and I put here, I put a circle here because this week is of paramount importance. So the problem that we are facing here is that if a person can be contaminated during 1 week, the virus present in blood, maybe in follicular fluid also, and the patient is asymptomatic. After that, the patient is symptomatic, and then the patient will create, after 2 weeks approximately, antibodies, and we will be able to detect the presence of IgG and IgM. But what is important is this first week, because again, the number of individuals in the population that has been in contact with the virus according to the experience published by the Spanish authorities and also French authorities, is about 4 to 5%, as I'll show you at the beginning. But still, if we want to play in the safe side, remember this week, because this is the dangerous one. This is the asymptomatic patient that may have been contaminated a week ago and is undergoing an ART treatment. So this slide shows you something similar. So when people have analyzed patients who were asymptomatic, who have a mild disease, moderate, or they were critically ill, it came out that after 15 days after initiation of symptoms, those who were obviously, who had a mild disease, were totally free of the virus. So 15 days for people who have been asymptomatic or mild disease is enough to reinitiate the treatment. But nevertheless, you will see how when we start the treatment, starting the treatment in these days that I'm signalizing here means to start with hormone replacement therapy for frozen embryo transfer or for oocyte donation, or means ovarian stimulation. We want to do a PCR to be sure that this particular patient is not in the in this first week of the disease, starting the disease. I'll show you in the previous slide. And one of the things that we still have to understand, because it is everything about the PCR analysis is not positive. I mean, there are some doubts. And one of the things that we still have to understand is why some patients are still PCR positive after being totally discharged and all the symptoms have disappeared, whether these patients are still infective or not, because in the end, remember that the PCR detects a virus RNA, so doesn't detect the presence of the virus. For this, you need to do a simultaneous culture. So it might happen that you have positive PCR patients and they are not anymore contaminated, that there are virus particles in them, but the virus itself is not present. But for the time being, we would recommend you that even if they do not contaminate, but as long as the PCR is positive, better they stay at home and you don't treat them. So basically, therefore, the conclusion is that the high performance PCR testing is essential to guide clinical decisions according to our understanding today. We anticipate that will become essential for guiding patients in reproductive practices, although the algorithms and the guidelines of the different societies are not, some of them are not using them and not using the PCR testing. It can happen that you have false positive testing, but this is very rare. However, false negative can happen and is always associated with the difficulty to get the nasopharyngeal swab. Again, as I told you, it can stay positive even after the infection is gone. And this is something that we still have to learn. And again, the study suggests that adults with SARS-CoV-2 infection are infections for about 9 days after the onset of symptoms. And this is it. But again, this is something that has to be clarified. And again, my recommendation, our recommendation would be that as long as the patients are positive in PCR, they better stay at home. So the other test is to look for seroconversion. When the antibodies appear, IgM, as you know, is related to the infection and appears approximately 10 to 14 days after the patient had symptoms, and the IgG basically follows a similar curve. Again, we recommend to use ELISA-based serologic testing because it has the highest specificity, and the sensitivity is about 60 to 98%, and this is what we are using. There are many commercially available tests. Some of them perform very poorly, so you better understand what your patients are getting and which is the sensitivity and specificity. Again, we still don't understand the degree of immunity that these patients have, to be honest. So we still have to be very cautious about that. But all in all, those patients who come to us and are positive for IgG are allowed to undergo treatment without any other restrictions. Let me show the next slide because I'm running short of time. I should be done in a couple of minutes. And my last slides are about our experience and the guidelines that we are using. These are the guidelines published by ESHRE approximately a month ago. And as you see, it is based on the presence of the antibodies. Patients who potential patients that prove to be negative, they go for treatment without any problems. Potential patients who go for treatment and they test positive for AGM and AGG, they recommend to be open-minded. And then patients who are with symptoms or proof positive for PCR obviously are asked to stay at home. We are more strict than the European Society, and this is our protocol. So before couples come to us to undergo any treatment, IVF, IUI, frozen embryo transfer, or site donation, we request serology. As said, if they are positive for IgG and negative for IgM, although today we don't understand the degree of immunoprotection that they have, we go ahead because at least during the days of treatment, that in the end is 15, 20 days, we can assume that they are protected. Now, if both are positive, they have to wait 15 days because, as I showed you, is the number of days that it has been proved that the infection is gone. And if both are negative, patient can start ART. But before the final treatment, before the collection of the eggs, before the insemination of the patient, before insemination of the eggs in egg donation, etc., they undergo a PCR. Why? Because this window of 1 week that I'll show you at the beginning, I told you this is the most important slide. We have a week where we really don't know where we are. And although only 5% of the population has been in contact with the virus, so the risk that this patient is contaminated recently is low. Still, if you want to be in the safe side, perform a PCR 2 days before real treatment. And this is our current experience. We have already managed approximately 1,500 patients. And as you see, 4% of the population is protected, is immune, as other statistics have shown. I spoke you about 5. In our particular experience, is 4. So same thing. IgM positive or PCR positive, very few. Out of 1,549, only 11 patients were asked to stop. And this is our experience in the whole IVIRMA clinics. When it comes to patients, to places especially sensitive, because the pandemic has been more severe, like the city of Madrid in Spain, the numbers are very similar. So more people have been contaminated, more people have been infected, twice as much. We are talking here about 11%, but again, the number of individuals is 1%, 3 out of 367 individuals who have to stop the treatment. So all in all, to summarize and to end with this presentation, I want to leave you with these ideas, why PCR is used to determine an active infection, and the serological test, because just to show that there was infection in the past. The reliability, again, the problem with PCR is that we do an inadequate sample collection. The problem with the serological test is different, but we recommend you ELISA-based tests. Again, when is it helpful? In our hands, we recommend to do it just before treatment, However, the serological test has to be done when the patient starts the preparation. So 15 days, 12 days before the real treatment, when the patient has to go to the operating room or to undergo embryo transfer. So first serology, and if serology is negative, nevertheless, we use the PCR. When it's not helpful, again, there are some issues that we should learn about the PCR test, especially those patients that remain positive, and because the PCR detects particles of the virus, and this has to be clarified. And then the serology test, we should again require them to be very to have the highest sensitivity and specificity as possible, and we have to understand when we are doing them and whether they mean that the patient is protected or not. Thank you very much for your attention.
Thank you very much, Dr. Pellicer, for a very clear presentation. We have already a number of questions that have been posted, so we will have time to discuss them later on. So now it's my pleasure to introduce Dr. Alecsandru. She is the senior immunologist in EB group, and well, she's going to speak on the assessment of hypercoagulability risk of COVID-19 in early pregnancy. We all know that that some cases that have reported with this type of disorders, and of course there is concern of how this could impact on pregnancy. So Diana has the clues and she's gonna tell us. Please, Diana.
Good evening, and thank you to all for your attention and time, and thank you, Ernesto, for your kind presentation. I will try to bring some details about a very specific aspect during the COVID-19 infection. With the coronavirus outbreak, concerns have been raised about its intrauterine transmission from mother to fetus in pregnant women and its related risk. And that's why, in order to reduce the risk of early pregnancies complication after embryo transfer, immune testing as IgG and IgM, as previously we just saw in a presentation of Professor Pellicer, and PCR are performed for patients planned for embryo transfer. And of course, their protocols can be changed from fresh to a frozen embryo transfer according to the test results, the immunological test or PCR test, as we just saw. The clinical manifestation of COVID-19 can vary, but among our patients, we can face to asymptomatic patients, to mild upper respiratory tract infections, and also something strange, such as acute asymptomatic walking pneumonia. And it could be asymptomatic. That's why it's very important to identify those infected patients prior to embryo transfer or early pregnancy. We can find this scenario into our patients. We can find positive, sorry, something wrong happens. Presentation. Okay, we can find positive pregnancy PCR SARS-CoV-2 test in those women under ovarian stimulation, prior retrieval, pre-embryo transfer, or waiting for the pregnancy test, or soon after positive pregnancy test. Despite of being a viral respiratory illness, COVID-19 may predispose patients to thrombotic disease, both in the venous and arterial circulations, due to an excessive inflammation, the platelet activation, endothelial dysfunction, and stasis. As we just saw, the host receptor used by SARS-CoV-2 is AC2. In addition to the lung, AC2 is highly expressed in other organs as human heart, vessels, gastrointestinal tract, and we just saw about reproduction tract too. The viral particles and the cell detritus of infected cells by endothelial cells and alveolar macrophages, triggering the generation of some kind of molecules we name pro-inflammatory cytokines and chemokines, as the famous interleukin-6. We have heard a lot about it in the last weeks or months. These proteins attract monocytes, macrophages, and these cells to the site of infection, promoting further inflammation and establishing a pro-inflammatory feedback loop. So, in a defective immune response, this may lead to a further accumulation of immune cells in the lungs, causing an overproduction of pro-inflammatory cytokines, which eventually damage the lung infrastructure. The resulting cytokine storm circulates to other organs too, leading to a multi-organ damage. And in this case, the endothelial cells could be infected, And that infection is of particular importance because this could lead to a severe microvascular and macrovascular dysfunction. But on top of that, this immune overreactivity, we can see here a lot of cytokines, immune cells, and inducing damage of the endothelial and vascular wall. And on top of that, this immune overreactivity can destabilize atherosclerotic plaques, and the progression of the systemic inflammation and the cytokine storm could lead to a fulminant organ damage as a myocarditis, a severe cardiac damage, acute coronary syndromes, arrhythmia, or disseminated intravascular coagulation and multi-organic failure. Part of this tissue damage is caused by the virus itself. We can see here the virus accumulation in the vascular wall, but an even greater amount is due to the immune system, trying to destroy and get rid of the infected cells. The damaged cells induce innate inflammation in the affected organs, and the vascular level, this reaction could be considered in terms of Pitchcock trial, which is a state, a hypercoagulability, a circulation stasis, and endothelial injury. Altogether could induce a very harmful and inflammatory reaction around the vessels. Abnormal coagulation parameters are associated with this poor prognosis in the patients with this novel coronavirus infection. And recently, we observed that the presence of the antiphospholipid antibodies induced by the presence of the SARS-CoV-2 virus can lead to thrombotic events. In critically patients, of course, it's more difficult to see where is the origin, because it's difficult to differentiate from other causes of multifocal thrombosis, such as disseminated intravascular coagulation, or even in heparin-inducing thrombocytopenia or thrombotic microangiopathy. And recently has reported that high cumulative incidence of thrombotic complications in those critically ill patients were in, and this is according with their hospitalization stay. But how is the point during the assisted reproductive treatment, the COVID-19 in ART 2020? The risk factor of thrombosis, of course, increased by the presence of the infection, but also during the hormone replacement therapy, during the pregnancy, or even the stimulation because of hyperestrogenemia. Pregnancy and hormone therapy has an increased risk. We all know this information, and this risk is increased for thrombosis if we compare to general population. During the ovarian stimulation, the risk is even more increased if we have a hyperstimulation syndrome during the ovarian stimulation. And in the meantime, if those patients having those risks already because they are under ovarian stimulation are infected with SARS-CoV-2 and get the COVID disease, so this risk increasing even more. During the hormone replacement therapy, the increased risk of thrombosis compared to general population seems to be related with the via of administration. It has been described an increased risk for thrombosis in those oral administration compared to general population. So those patients under oral administration or hormone replacement therapy getting a COVID are exposed to an increased risk for thrombotic disorders. But in the meantime, studies show no risk compared to general population when transdermic administration is selected. So in this case, the COVID apply a risk for thrombosis, but the transdermic administration of hormone replacement therapy seems to be safer than oral one in order of the risk of thrombotic risk. During the pregnancy, the risk of thrombosis is even higher if that pregnancy happened after an IVF with the hyperstimulation syndrome. To this, the presence of the COVID-19 increases more than 100 the thrombosis risk. So those pregnancies after an IVF of hyperstimulation getting COVID are a high risk for thrombosis complication. Taking all those, to go ahead to the next slide. Okay, taking all those observations together, the Spanish Society of Gynecologists and Obstetricians and the Spanish Society of Thrombosis recommend a prophylaxis with heparin, low-weight SARS-CoV-2 infection, mostly in those patients under hormone replacement therapy, those pregnant women, any trimester of pregnancy and postpartum. The time is depending of the severity of the disease and if it's postpartum or in the early pregnancy. And of course, they recommend to take into account this protection with heparin for those patients under these circumstances having a known thrombophilia, previous one. We know that many of our patients have already the thrombophilia panel, so we have this information, and it's a very useful information to get to the next doctor, which will be in charge of the COVID disease for our patients. Regarding our specific field, assisted reproductive treatment, we work medical work team, and we propose a protocol. Those patients under hormone replacement therapy, we recommend to have better transdermal estrogen than oral one. And if they have a PCR, positive PCR prior of embryo transfer, we will stop the hormone therapy, and of course we will stop the embryo transfer, and the patients will be referred to the primary care for considering the low molecular weight heparin for prophylaxis. If the PCR is positive for the patients waiting for the pregnancy test, then if the patient is under hormone oral therapy, consider change to transdermal estrogen, and of course the protection, the heparin. The protection is recommended to be done for 2 weeks, but of course again, the doctor into the hospital will decide if the patients will receive a longer time this prophylactic according to the stage of the disease. Of course, if the PCR will be positive soon after the positive pregnancy test, again, consider change the transdermal estrogen and of course the low molecular weight heparin in that case for 2 weeks, and refer the patients to the hospital. When the patient is under ovarian stimulation and we receive a PCR, positive PCR prior or retrieval, we will stop the stimulation. The antagonist administration is highly recommended, and the use of prophylactic heparin until the menstruation. If the patient is positive, waiting for the pregnancy test, of course, we will start with the low weight, the molecular weight heparin as prophylactic dosage for 2 weeks, and the the doctor in charge of her COVID will decide if this will be necessary to be longer according with the COVID disease stage. If the patients had recently a positive pregnancy test, so definitely we will recommend to have a prophylactic with the heparin for 2 weeks, and again in the hospital, if it will be a need for hospitalization, it will be probably a longer time. So if the patient has some heparin allergy or heparin-induced thrombocytopenia, so fondaxaparinus is highly recommended to protect those patients. In this case, we have a team working for those protocols. These are our protocols at this moment, with all the data published already and analyzed, and all the recommendation for our societies of gynecologists and obstetricians, and also thrombotic society. But of course, in the future, those things could change according to the higher amount of information of data we could receive through our publication. I'd like to thank you all for your attention, and especially for our medical work team, to Dr. Joana Peñarrubia, gynecologist from IVIRMA Barcelona, for its valuable contribution to this work, Vanessa Vergara, Marta Romero, in charge of COVID patients in the public hospital, and also collaborating with our immunology unit in IVIRMA Madrid, Romina Dielli, clinical immunologist at IVIRMA Barcelona, and of course our Chief Medical Officer, Antonio Requena. Thank you to all. It was a long time, but very useful, and we all hope this work and this conclusion will help to protect a lot of our patients. Thank you.
Thank you very much, Diana, for a very, very interesting presentation, and I'm sure there will be more questions. Indeed, we have been already receiving some of them, so we will keep going after the last talk. And now is the turn for Alberto Vázquez. He, as mentioned, he's the senior surgeon of the EV group, and he is going to talk us about the safety in front of a surgery in the OR room for preventing coronavirus infection. So Alberto, it's your turn now. Thank you.
Okay, thank you, Ernesto, for your kind introduction. All the people in the other side of the screens, thank you for being here. It's the time for me to speak about a little bit about surgery and safe protocols. I must say that thank you for the introduction, as I said, but I think the senior surgeon here is Jaime Ferro, and I really happy to learn with him. So we'll go through the talk. First of all, I have no conflict of interest to declare. This is the little index I will follow. I will speak about some objectives at the beginning. Remember with one slide the mechanism of transmission, and then the prevention general and specific measures we are using, and some conclusions to end, okay? Well, the objectives of this talk, of these safe protocols, are to prevent the risk of the coronavirus infection and to perform the surgical activity with the maximum safety and efficiency. The mechanism, as you know, is mainly between people by respiratory droplets that are more bigger than 5 microns and produced when infected person sneezes, for example, and by contact with surfaces. Even this is controversial. Regarding the OR, and this is particularly relevant, we can have a transmission also by aerosols, where the particles are less than 5 microns. And then this is important when we are in the OR regarding the anesthesia, and we will go in detail after regarding also the surgical smoke we can produce during surgery, or even when we have some release of CO2 during a laparoscopy. we start with I will start with the general prevention measures that are regarding the screening and test of the patient and workers, then the protection measures, and to end the cleaning and disinfection measures. What we do to all patients before coming to the OR for a triggering or a hysteroscopy, laparoscopy, we perform a PCR test 2 or 3 days before. If the result is positive, we cancel the procedure. We also test people working, and for that we use the serological test and we act according to the results. So I don't want to go through that, but it's a protection, a measure that we use. And of course, that is seems to be obvious, but I think probably these are the most important measures we can take, because when we are in the OR, the interpersonal or physical distance many of the time is impossible, okay, to maintain. So remember to use the personal protective equipment. Consists of the respiratory masks like the FFP2 or 3. These are the ones with the European standard. The N95 is the same. We use above the surgical mask, we use the facial screen, the disposable and waterproof gowns, and of course gloves. This is all you know about that. 2 more things before going to the disinfection. Only those people that is strictly necessary for the procedure should be inside the room, okay? This is important. And of course, the surgery should be performed by the most experienced surgeon. As you know, and this is published in many studies, the skills, the experience of the surgeon is related directly with the result of the surgery, and this is good and a benefit for our patients. About the cleaning and disinfection, well, wash hands, of course, and intensive cleaning of the OR. I was looking in the World Health Organization about that. I found some interesting things. We know in some studies that were conducted under laboratory conditions, but without disinfecting and cleaning. We found the persistence of this of the virus, of the SARS-CoV-2, in different surfaces, can stay till 1 day and close 2 days on glass. But what is important is that the contamination of these surfaces by this virus has not been linked to infection transmission in this case. But as this has been proven in other respiratory viruses, we think the cleaning and disinfection measures must be taken. As Professor Pellicer say, I like a lot, we must be in the safe side, okay? What we do, the cleaning is with water, soap, okay, to remove the pathogens, and then we know this is the first step. The progress should be from cleanest to the dirtiest part and from the higher to the lower surfaces, okay? Then we must use a chemical disinfectant such as hypochlorite or alcohol, and it should be applied after cleaning to kill the virus, okay? The concentration, 0.1% seems appropriate, but when we are doing surgery, stereoscopy or laparoscopy or others, we can have some body fluids, so concentration of 0.5% is recommended. In indoor spaces, the routine application of disinfectants by spraying or fumigation is not recommended at all for the SARS-CoV-2. The specific prevention measures are focused on the oocyte retrieval, hysteroscopy, and laparoscopy. We can say that ovarian punction is safe, okay? It's not an aerosol generating procedure, and specific measures are not necessary, okay? With the general prevention measures is enough. If we have a positive PCR test before the retrieval, we cancel the ovarian punction, and it's imperative to have the test before the triggering, because imagine we have it after, we could have some difficulties to take decisions, okay? For hysteroscopy, is not considered also an aerosol generating procedure. We can have some specific considerations. like the use of electrosurgery during the operative hysteroscopy, can produce some smoke, but this remains inside the cavity. And when it's going outside, it's going through the outflow of the shields of the hysteroscope and can be absorbed into circulation. So don't be scared, be safe to perform hysteroscopy. And current scientific evidence indicates that SARS-CoV-2 is not present in the female genital tract. Some specific recommendations, because if you are aware of the smoke, use the suction devices, connect to the outflow sheets, of course, especially if you are doing resectoscope. The hysteroscopic tissue removal systems are a good option because they don't produce smoke, and the aspirated material should always go into a closed system. So what must we do? We should apply the recommendations we usually apply in our daily practice, speaking about hysteroscopy, okay? Well, as we are speaking about surgery, I will put this video. Here in IVI, the technique we use, and in this pandemic with the COVID, we don't use energy too much, okay? We use mainly cold cut with microcisors, and then we perform a small coagulation, bipolar coagulation with a tip of 1 millimeter. So we are happy because doing that, we don't produce smoke. So the risk of even the virus is in the smoke, the risk of transmission is really, really low. Okay, I will put a little bit. Okay, so this is the typical TY shaped uterus. For us, this is not normal. Okay, if we find this kind of uterus, people with a pregnancy loss, with the implantation failure, we prefer to make the surgery, the metroplasty, and to convert the cavity in a triangular one that is normal shape. What we do is we start in the fundus. Always we perform only one cut-on line without reference or our landmarks that are the tuval ostia. So we go from one to the other. We start normally in the left side of the patient. We move to the right. Okay, and carefully cutting. As you can see, no energy at all. We don't use the tip or anything. We use only that. We cut and we follow the line. This is in the fundus. And then, that is also important, I think probably more important than the fundus, we cut these prominent walls. We use the fixed part of the scissor till the wall, and then what we do is a straight line from the isthmus, that is our limit, till the ostia. Then we can change the shape of the uterus, making triangular, that is normal shape. At the end, we can do some small coagulation with this bipolar tip, and the surgery is finished. We do it because the results are good doing that, okay? The live birth rate is higher and is published. So, to end, laparoscopy is probably the more controversial step here. It's considered aerosol generation procedure, requires intubation, and some specific considerations to keep in mind if we speak about laparoscopy. Well, the pneumoperitoneum brings the risk of the aerosol exposure to the operating team. Can be, of course, intentional or unintentional when with the release of the CO2 outside the cavity, okay? When can happen that? It's more likely to happen during the insertion or removal of ports, during the introduction and removal of the ports, during the specimen retrieval, and during the removal of the pneumoperitoneum at the end of the surgery, okay? I want to remark that the presence of the virus in surgical smoke, although unlikely, is a possibility. So taking that into account, these factors, the aerosolization of viral particles during hemoperitoneum, general anesthesia with intubation, extubation, surgical smoke, some people say that laparoscopy should be avoided and laparotomy universally performed when patients are SARS-CoV-2 positive or their status is unknown. Well, I must say that I totally disagree with this argument. I will explain to you why. Okay, of course we have some risks, but what is published? What is in the literature? What do we know about that? What we know is that the SARS-CoV-2 is a respiratory pathogen. Of course, we know that. And other similar viruses like influenza, SARS, MERS, there is no evidence of disease transmission through the surgical smoke or the laparoscopic gas, okay? And the virus has not been identified in surgical smoke. Remember when we were speaking about the disinfection, we didn't find that when the virus is in the surface, we cannot prove that there is a risk of transmission of the infection if we touch the surface. It's true that other respiratory viruses have proven that, so we take precautions. But here in laparoscopy, not even the respiratory viruses are in the smoke, or the infection can be transmitted by laparoscopic gas. So be quiet. This is not a big deal during laparoscopy. Then imagine there is a virus in the smoke. So going to the safe side. So the containment of the surgical smoke during laparotomy is challenging, if not impossible. In laparoscopy, the gas is all the time inside the abdominal cavity. The general anesthesia, that is probably the crucial step, is usually used in laparotomy. And what is for me important, we have some benefits when we use the laparoscopy instead of laparotomy. And in these times of pandemic, they are really important to keep the resources, the precious resources of the hospitals, because the recovery of the patient is fast. So less hospital stay. So let the hospital for COVID patients, less complications and less use of intensive care units, and of course, a better quality of life. So I should say that if laparoscopy can be performed, let's do it. Don't do laparotomy. Only if there is a surgical indication for that, of course. To end, some recommendations. If we want to minimize the CO2 release, close the taps of the pores before inserting them. This is logical, obviously. Attach CO2 filters to one of the ports, at least for the smoke evacuation, could be the ULPA or the IPA filters. Minimize the introduction and removal of instruments through ports to avoid the leakage of the CO2. For a specimen retrieval, and at the end of the procedure, turn the CO2 off and then deflate the abdomen with a suction device connected to the port with the filter, okay? To minimize the smoke, reduce the use and intensity of the diathermic and ultrasonic energy. And regarding anesthesia, that is the crucial step. Minimize people in the ER during the critical phases as intubation and extubation, and minimize the Trendelenburg and work with low pressure to facilitate mechanical ventilation. And to end, remember, so we know we have these measures, this general, this specific for laparoscopy, stereoscopy. We must train people to use properly, to wash hands, to use the gloves, the mask, etc. And of course, to train to do surgery. Don't hesitate to train people. As you can see, I like this, that CFO asked the CEO, what happens if we invest in training and then they leave us? And the CEO said, what happens if we don't and they stay? So let's train people to do the things properly. To end, conclusions. These are my conclusions. The general anesthesia with intubation is the most risky virus transmission. The general prevention measures must always be taken. The ovarian punction and hysteroscopy are safe regarding the virus transmission. Laparoscopy is also safe and offers more health benefits than laparotomy. However, some precautions should be taken, and train your people to protect themselves and make the surgery safer. Thank you very much. I hope it's useful for you to talk.
Thank you very much, Alberto, for a very nice presentation, very, very graphic and very clear also. I'm sure that especially the surgeons in the audience have enjoyed it, and that for sure it will raise some questions. So we have time for questions. We have 20-30 minutes for questions, and there are quite a few of them already uploaded. And I encourage, we have more than 250 people attending at this point. And so any of you that may have questions, you are still on time to posting them. So I will follow the chronological order of the presentations, and to start with the Q&A session, although I guess that new questions will arrive. So Dr. Pellicer, I will start with some questions I have for you. There is concern about the potential effect of the disease in the first trimester, as obviously there is very little reports in the literature. So the questions are in the direction of how could fever result in even some teratogenic effect in these early stages of pregnancy. What's your opinion on that?
Yeah, this is a good question. We really don't know. What I can tell is that before we closed our facilities, we already were very much determined to do a follow-up of all the patients that were pregnant during the pandemic. And we are following them. So we will have answers maybe before we get all the answers, because we need obviously to finish the pregnancies. We get some answers from China, which has been a trend during the pandemic. So the Chinese obviously are more experienced, and they suffered they started the pandemic before us. But so far, we don't see any increase in miscarriages. And again, patients need to arrive to the week in which the morphological ultrasounds are performed. So we need some time to answer to that question.
Sure. Another question also for you, Dr. Pellicer. Why are we stopping patients with a positive PCR in front of pickup, or why not to consider freezing all the embryos in these cases and see what happens?
Well, this is simple to answer. The first reason is because we care about our staff. So we don't want infected people around us. This is one of the main objectives. So if somebody is positive for PCR, should go home and stay there for at least 15 days and come again. So again, their second reason is because as I showed you, the receptors that the virus need to enter into the cells are present in the oocytes. The oocyte is protected by the granulosa cells, but if we don't know if the virus is present in follicular fluid. If you do the pickup and you start to manipulate the oocyte because you remove the granulosa cells, and the washing is okay, but some virus is there. So, you are accepting a potential risk that you shouldn't, okay? And nothing is wrong with canceling the cycle even 48 hours before triggering of ovulation. The problem would be if you perform the PCR after triggering, then you can get OHSS, you can get other complications that have to be balanced against the minimum risk of contamination. But we perform the PCR again 48 hours before ovulation triggering for this particular reason, and those who are positive go home because you have to protect your staff.
That's a good point. And more concern regarding the potential contamination on the sperm. What's the point of testing the male, given the evidence that there is no contamination on the sperm so far?
Thing. The same. I mean, everyone that enters in a closed space has to be tested because if they are infected, we are putting at risk our staff and the rest of patients. So everyone that enters in your clinic, we have to exactly know what's going on. It's not about that the sperm can be contaminated or not. It's about that a certain individual can contaminate others.
So this is so probably this is also the rationale for doing the serologies before starting the treatment and not just waiting for the PCR at the end, correct?
Exactly. The PCR in the end is something that we have applied. At least is different to what the other societies like the HRA is doing. And again, it's justified by the fact that 1 week, there is a week where the patient can be asymptomatic and already the virus replicating like crazy in their bodies. That's the justification of the PCR. But you are right. If we are able, we should test the patients before entering into entering in the treatment, starting the treatment to get an idea where we are.
So probably and to make to draw the picture, probably what we should really be concerned is about the horizontal transmission much more than about vertical transmission. Is that correct? Is that what we could understand from all these practices, right?
Yeah.
So maybe could we think that if at the end the virus goes down and is less virulent, everything else, all these preventions that we are taking could be abandoned in the next future? Or I know this is just an opinion that I'm asking for, or this is going to be here to stay.
No. I mean, I think it's a very good question. Again, I mean, people may say that we are exaggerating because, in the end, what this pandemic, these 2 or 3 months have shown is that only 5% of the population is exposed to the virus. Okay. Now, there is also some evidence in vitro coming from Italy that says that the virus is losing virulence, so there is getting less and less dangerous. I hope so. So I think that my prediction is that in the near future, the whole thing will be treated like a regular influenza. But now we are just, at least here in Europe, we are starting to go out to do some sport, to do some shopping, to get a beer in the bar. So we have to be very cautious. But we will lose this fair. Slowly, we will lose this fair.
Yeah, and because also this links with other concern of some of the attendees, and in regards the costs of the tests. Do patients have to pay for the test? How much are the tests? And I would add also, how often do we need to test patients at this point? Because they are facing now their first treatment, but those patients failing and maybe are coming back in 1 or 2 months. And should we repeat the test, right? What are we gonna do?
You should repeat the test. The cost is about, I think, is about 120 euros the PCR, and I don't know, it's about
40. The serologist is around 40 euros.
40 euros. So we are talking about 150.
No, 120 is both things. It's 40 for serologists and 80 for the PCR at cost. This is just at cost.
Yeah, compared to the total cost of us. ART
Right.
cycle is nothing. So
probably the benefit risk justifies
yeah.
the expense. Well, okay. Thank you very much, Dr. Pellicer. Yeah, again, both partners might be tested. So I have now a question for Diana. Diana, what do you think about the administration of Adiro 100, AAS 100 to prevent multifocal thrombosis? Is this effective, or do you think that this is not enough? What do you think about it?
The aspirin, the baby aspirin is not enough for such a big injury, the endothelial injury, and the risk of thrombosis in these patients. Because of this inflammatory and exaggeration of the activation of the immune system. So there are several factors in the heparin could prevent against the hypercoagulability, the stasis into the vessels, not only as a modulator into the endothelial wall. So the heparin is the indication and the aspirin is not enough. And probably in some patients could increase even the risk of bleeding. But I'm talking about some very critical ill patients, not for our mild or asymptomatic patients. So it's not an option, and the protection is the heparin because of all those mechanisms, hematological and vascular and immunological mechanisms.
And within this regard, Diana, what would be your recommendation for patients that are being treated for acute HLA, or any other immunological anomalies detected during an implantation failure study? Are there increased risk? Should we take any additional precautions on this population?
It's a very good question. You know, the KIR and HLA maybe in this field is more famous because of this mismatch regarding the reproductive function and the pregnancy outcome. But they are present in our natural killer cells, even in the peripheral blood natural killer cells, and are very, very useful for the infection bit with the virus. So the natural killer cells in peripheral blood have their own KIRs, and we know that certain combination, even KIR and HLA-C, are more effective against infection, as even the KIR-AA. It's very useful to fight against malaria or Ebola virus, which are very, very more complex probably than coronavirus, but from a reproductive point of view are not so efficient. So there are two arms, which is best for the protection. That's why at the end of the pandemic, when the population is shorter, the pressure for reproductive will lead to have more baby, those women having activating receptor. So in this case, it's another way the natural balance the HLA-C and the KIR in the general population to have C1, C2, KIR-AA, AB, and to keep growing our number of people in the world. So if a couple have this mismatch problem, is not more exposed to infection, probably is more protected because their immune system is more able to fight against the virus. Not so good for reproduction, but yes, for survivor in an infectious environment. So there isn't any concept about this typing. And about immune treatment, when we face with patients having an autoimmune disorder, they have the same risk as the general population. We have a lot of information about the immune suppressed patients in the transplantation or autoimmune disorder as rheumatoid arthritis and lupus. So depends of how severe will go their disease, and the protocols in their treatment will be changed according with their evolution. but at the beginning are not the higher risk than the rest of population. And in our field, we face with young women generally. So we know that the infection is not so severe in this case.
Yeah, lucky for us, huh? Thank you, Diana. I have a question now for Dr. Vázquez. Alberto, have you changed the type of anesthesia for the pickups, for oocyte retrievals?
What we have done is we try to minimize the aerosolization because the anesthesia is the crucial part of this infection process. So we normally, our anesthetists use spontaneous ventilation. If this is not possible because we regard the patients before, we move to local regional anesthesia.
For pickups?
Yeah.
For pickups. And of course, Go ahead, yeah, sorry.
No, in difficult cases, you know, if the anesthetist cannot keep spontaneous ventilation, we prefer, because normally we use the propofol, we prefer to move to local regional, like epidural or, yeah.
So I understand that for hysteroscopies it's exactly the same, right?
Yeah.
And a particular question within this regard, in a case of just a diagnostic hysteroscopy that is going to be performed on consult in the office without anesthesia and a patient that is asymptomatic, should we perform a test for COVID in this case before?
Well, this I think I agree with Professor Pellicer. Okay, you know, when we have we want a safe environment, I think the test will help us to avoid contagious to other people. So if the patient is coming to us, I prefer to have a test before doing something with the patient, even it is an ambulatory or diagnostic hysteroscopy. I should test the patient. Yes.
Okay. Yeah, keep going with the hysteroscopy. In the case of a metroplasty with bipolar resector.
Yes.
Because of the aerosol generator procedure, is this still safe? You already showing the video that we use the cold scissor, but what would be what would be the risk of using a bipolar resector in this case?
Okay, this I explain. There is no proof that the virus is in the smoke. Then there is no proof that even if it is in the smoke, we can transmit the infection to the patient. Okay, so if we perform the hysteroscopy, we use water. We don't use gas. This should be another thing, okay? But we use water, and in the normal way we perform is, in my opinion, and what is written in the literature, I think is safe. Okay, so we can go and perform hysteroscopies without problem. We should apply the measures we apply every day to put the suction of the liquid to a content, and that's all. Basically, is that.
Yeah. More questions. This regards for laparoscopy. In case of elective surgery, and based on the fact that anesthesia seems to have higher risk than laparoscopy, the anesthesia itself, for contamination of the medical team. Yeah. But also for increasing the severeness of an asymptomatic or false negative test results done before the surgery from the patient side. So the question is, how can we still defend elective reproductive surgery at this point?
How can we defend?
Yeah, how I mean, what would be the reasons why we are supporting the performance of elective surgery at this point?
Well, if we test people, I think this is the clue. So if we test people and the PCR is negative, we go through the surgery. Now, you know, if you want to have baby and you have something that can make more difficult the situation for you, so I think the idea is to perform the surgery. If not, we cancel also the cycle. So if we have the PCR test, negative test, we perform. The question should be, okay, we have some emergency laparoscopy because ectopic pregnancy, we should go on even in COVID positive patients. We take precautions. I think with that, there is a risk, but the benefit is higher than the risk in my point of view. So we can perform, nowadays, in this situation with the hospitals that are not blocked, so we can go free and perform elective surgery, in my opinion.
Yeah, my question would be now, where has evidence-based medicine gone? I mean, how much are we based on just theoretical knowledge, not supported by the facts? I mean, to what extent the panic associated to the pandemic has put evidence-based medicine aside? We are not basing our behavior on that.
I agree completely with you. We are not following to take these precautions. I already explained in the talk. Not evidence-based medicine for transmission through surfaces, not evidence-based medicine for virus in the smoke, not in the gas in laparoscopy. I don't know, but you know, only respiratory transmission. Okay, put the masks, take the gloves, wash the hands. So at the end is that.
Yeah, I mean, it's a matter of common sense, probably, right? A balance. It's a balance between common sense and cost benefit, risk, etc. Probably there is no right position at this point. And at this moment, we don't have the data to say this is right, this is wrong. And we need to see what's happening. And as Professor Pellicer said at the very beginning, everything what we're saying today, it might be used in our country in a few days, right? More questions. I go back to Dr. Pellicer. No, one more question for you from Guillermo Marconi, Alberto. It is not proven that saliva aerosol is the same as blood aerosol. So there is no reason to avoid laparoscopy procedure, as you were saying. While in the laparotomy, it's very common to be spitted for a vessel direct in your face. So probably danger is the same, or it does not exist, right?
So?
No, I mean that on the theory that you mentioned that some authors were recommending laparotomy in front of laparoscopy.
Yeah.
The comment of Guillermo Marconi is that the risk of getting spitted by a drop of blood in the laparotomy is higher, and therefore the risk of aerosol transmission, because it's blood aerosol instead of saliva aerosol.
Yeah, I think of course it's higher, and it's for that. This is another reason, you know, during laparotomy this is a risk. During laparoscopy is not a risk, because you know everything is contained in the abdominal cavity. It's another more reason to perform laparoscopy if it is well indicated. Of course, you have indications for laparotomy for sure, but don't ban laparoscopy and say you cannot do it, you must do everything by laparotomy. I think this is not fair, and it's not evidence-based medicine.
Decision should be taken as COVID, if COVID was not there, right?
Yeah, of course.
This is the message.
Yes.
Yeah, clear, very clear, Alberto. I have a question that is for the three of you, well, it is a short case. I mean, if we have a patient with a high response, and it's just about couple of days before pickup day of triggering, and now we have a positive PCR. Should we still cancel this cycle? Would not be more dangerous in the risk of OHSS, in the risk of hypercoagulability in this patient to go ahead instead of stopping the procedure? What's your opinion on this point?
Well, if I start, I would say that we clearly stated that the PCR should be done at least 24 hours, around 48 hours before pickup. So before triggering. Now, you can say, okay, the patient did the triggering and the day before pickup comes to you with fever, and then so you have to decide between canceling and going ahead, because she got the triggering injection, okay? Otherwise, there is no case. If there is no triggering, there is no case. If there was triggering last night and this morning the patient has fever and becomes positive, Well, then, as Dr. Vázquez said just 2 minutes ago, I mean, you have to balance the risk. Maybe you have to go ahead and take protective measures, etc., etc. And this will be probably, I would recommend to freeze the oocytes, so to avoid that these samples are 5 days in the IVF lab until they become embryos. Regarding contamination in the vitrification tanks, which may be also an issue, I don't think this is an issue, although so far nobody knows. But we published a study a few years ago in which we looked at the potential contamination in frozen oocytes with different viruses, HIV, hepatitis, and some others I just forgot. But the bottom line is that we shouldn't be concerned about transmission into the liquid nitrogen tanks. So only in this case that the ovulation triggering has been done, that the patient has, has fever the following day, we could consider to freeze the eggs. Yeah.
And linking with this comment, there's a question, interesting question. It is the presence of receptors in the embryos, the same amount of those present in the oocyte. Do we know that? And even is there a difference between fresh and frozen embryos or eggs regarding the concentration of receptors? Do we have any data on that?
No, we don't know. We don't know that. The presence of both receptors have been shown in oocytes. In embryos, only one of them, ACE2. But we really don't know. I mean, most of these studies also come from in silico data, so come from databases, and we need still more information. But it looks like, again, like there is no high risk in the gametes, especially in the sperm for sure. In the oocyte, the risk is very little. And regarding fresh or frozen, I really don't know. I really don't know if freezing damage the receptors or not. I have no idea.
So, and given this, I mean, as somebody is suggesting, is there any point on using separated tanks for these patients on the storage of their eggs or their embryos? Well,
this is what I mentioned. What we learn from using other viruses in an experimental model, etc., of oocytes, there was no risk, but who knows? I mean, we use separate tanks for so many things that I would recommend to use a separate tank.
Well, thank you very much. I think that well, we have covered a good number of questions, and we are almost covering our time also. So so I think that we can stop it here. We don't have more questions. So I would like to thank all of you for your very clear presentations and very informative, all of them, because for the time being, there is, I mean, we are sunk in information, and it's very difficult to separate that the good information, the reliable one, from those that are not. So everybody of us is in the need of understanding what's going on. And I want to thank also the audience for being there and for being so active, making questions. Thank you very much for that. And just to thank you and say goodbye. Hope to see you around soon. Hope to see you physically, most of you. We will all appreciate that. Thank you. Take care. Stay safe.
Thank you.
Bye. Thank you.
Bye-bye.